Next, we have Dr. Vignesh from Bangalore presenting emerging biomarkers in OSA, current evidence and future directions.
Hello, good morning, everyone. At the outside, I'd like to thank the organizing team for giving me this opportunity to present. So, for years, we have been diagnosing OSA by the number of respiratory events, but the patient's morbidity is not from the number of events he is facing, not only the number of events, but also is the biological damage which he ends up getting as a consequence of those repetitive apnea and hypopnea events, which is nothing but intermittent hypoxia. For surgeons, it took a lot of time for us to even decipher so much data from a PhD. Now, how does this biomarkers add on more information to manage our patients? That's what I'm going to briefly sensitize. I'm not going to go in depth because it's beyond the time limits. So, going ahead. Now, what are the AHI limitations? AHI limitations where it was not giving us data on what is the consequence of intermittent hypoxia at the cellular level. Let it be the biological damage in terms of inflammation, oxidative stress, cardiovascular morbidity, metabolic dysfunctions, and neural injuries. These data were missing, and that's where these biological markers help us to identify them in a better way. Now, every apnea starts with a hypoxia, and these repetitive intermittent hypoxia, they trigger an oxidative stress, and this oxidative stress triggers the vascular damage and the endothelium, and the chronic injury leads to fibrosis and end organ damage. And these, every step of the pathways leave a fingerprint, and studying those fingerprints is nothing but the biomarkers. Now, let's assume there are two patients with similar AHI, similar oxygen desaturation index of 30. Now, this is what we are all being trained to do: see the AHI, see the ODI, see your NREM, REM sleeps. But one thing which I personally have been missing out on not concentrating all these while would be hypoxic burden. Now, why hypoxic burden is so important? This is one physiological biomarker which doesn't require a blood test. We just can, it's an extension of your PhD, and this is one important tool to assess your intermittent hypoxia. Now, as you could compare in both patient A and patient B, see, your ODI only measures the number of events. It doesn't give you a clue regarding the depth of the hypoxic events, the frequency of your hypoxic events, and also your recovery time. So, your hypoxic burden is a curve which inculcates all of them: your depth, frequency, duration of your intermittent hypoxia, and also your recovery time. Because most of the injury at a cellular level happens during your reoxygenation level. So, two patients with similar AHI, you again can't look at them the same way, because the first thing you want to see is hypoxic burden, because that is what is causing damage for the patient. So, it's one of the hypoxic burden is considered one of the best currently available PhD derived surrogate of intermittent hypoxia, because it incorporates, as I already mentioned, all of these data about intermittent hypoxia, and pathophysiological mechanisms are believed to drive these cardiovascular injury than AHI alone. Now, as you could see in the curve, why is recovery time very important? As I already mentioned, that is where most of the damage, cellular damage, reactive oxygen species damage is happening during your reoxygenation time, which is not calculated in any of your other metrics, let it be AHI, let it be ODI. The recovery time, it reflects how long the tissues remain oxygen deprived after each respiratory event. Longer the recovery, the oxygen depth is increased, the oxygen stress is increased, the autonomic activation is more, and the endothelial injury is more. So hypoxic burden therefore doesn't only measure your oxygen falls, but also how long it stays below your baseline. So the ideal studies to calculate hypoxic burden is a level 1 and level 2, because the denominator for your hypoxic burden is your total sleep time. The downfall with a level 3 study is it doesn't measure your total sleep time, it is total recorded time, which can underestimate your hypoxic burden. Okay. So there is no international guidelines yet. It is only a research guidelines that if your values are less than 20 to 40 or in a safer limit, anything above 40 to 60 and more than 60, you are in a very high burden of hypoxia. So another table to summarize the importance of intermittent hypoxia. Now, AHI, one thing was we were asking how many times the airway collapses. Hypoxic burden asks how much oxygen depth did these collapses impose. Hypoxic burden therefore reflects cumulative injury than your event frequencies. And how is it important for us clinically? Because it helps to stratify our patients. It guides to for better treatment. Patients with similar AHI but higher hypoxic burden, you want to make sure that either before your surgery or after your surgery, patients are adequately managed with CPAP and multimodality treatment. And it also helps to assess your treatment response. Quite a few times we have had cases where post your surgery, the AHI will remain the same. Patient will come and ask you, sir, I got the surgery done, pre-op was 30, post-op is 40 or 18, I'm not seeing much improvement in the values. So one thing which you can see in those curves later would be the improvement in your hypoxic burden, and if it was not sufficiently treated, you need to add on your other treatment like CPAP and other modalities. So it is helpful post-treatment as well to assess your response to treatment. Another physiological parameter which we need to pay attention is heart rate response. This focuses on your your hypoxic event, what's the increase in your heart rate, acceleration and deceleration, and the overall magnitude of increase in your heart rate. The increase after each respiratory event, this reflects your autonomic nervous system responsiveness and your sympathetic overactivity, the cardiovascular stress overall. Okay, so for example, if the values are less than 6, that means a patient might be having autonomic imbalance like diabetic mellitus or advanced cardiovascular disease, or patient may be on a beta blocker. And if the values are more than 15, these are severe OSA patients or patients who are at very high risk for hypertension. Now, all these now we understood regarding your physiological biomarkers. Now coming over to what is happening inside your cell. The first thing I would like to take your attention is your oxidative stress damage. Whenever the cell undergoes hypoxia and the stress damage, the first thing which gets recruited is your hypoxic induced factor 1 alpha. This stimulates multiple genes to increase your glucose utilization, increase your vascularization through vascular endothelial growth factors, and increase in your erythropoiesis. So these biomarkers indicate your oxidative stress which is happening. The other next step would be once this is going on, other thing which is happening in your cell is your inflammation. This mitochondria undergoes damages and they release electrons, which creates more of reactive oxygen species, which causes damages to your lipids, DNA damage and other proteins. And DNA damage byproducts, they increase your 8-hydroxydeoxyguanosine, which is again a biomarker to assess the level of severity in OSA damages. Next, the inflammatory markers. You have multiple inflammatory markers. The most commonly studied are your interleukin 6, which is the first cytokine to be increased, and the other one to increase as a consequence of interleukin 6 is your high sensitive CRP, which most of the time when a patient comes to you with a routine blood test, one thing which we keep seeing is your CRP, increased CRP in a normal patient without infection, or increased neutrophil and lymphocyte counts in relative to your platelet count. So these all indicators of the patient is having a systemic inflammation. Most likely that you have to start screening for sleep apnea. So, and you have also markers for endothelial injuries, which is again a consequence of your intermittent hypoxia and reactive oxygen species. The final byproduct is your damage to your endothelium. Even before the patient undergoes any cardiovascular morbidity, the first organ to get damaged is your endothelium. That is what going to end up with your multi-organ damages on the long run. So, as a consequence of your injuries and inflammation, the tissue ends up undergoing fibrosis. So, these biomarkers like galectin-3, TGF-beta, matrix metalloproteinase, these helps to assess the amount of fibrosis which is going on in a patient, which usually will be high in severe OSA cases. Post-treatment, these values generally come down. It's not like it is completely reversed, but they come down usually. And one more thing I'd like to add is, say for example, you operated on two patients with similar AHIs, similar ODI, similar DICE finding, but their healing may not be the same. At times we have seen their healing between two patients may not be the same. This slide probably explains why two patients might have different remodeling phases prior or like post-surgery. So in future, probably once we are able to identify these markers clearly, we might pick and choose certain cases where the fibrosis is already less, and also we can help to monitor the cases how the fibrosis post-surgery as well. And other silent organ damage which we tend to ignore is the neurocognitive dysfunctions. So whenever there's endothelial damage, other damages which is quite common is your neuronal damages. One important markers are neurofilament, light chain, glial fibrillary acid protein. These cross your blood-brain barrier and easily noticeable in your blood and CSF fluids. So the future is going to be a combination of your genetic study, proteomics, and all this put together. Now it's known as omics evolution in OSA, where it's not one biological marker, but it's a study of multiple biological markers through which we are able to identify prior even to the patient is developing a disease condition, and also it also helps to you maintain, let's see what state the patient is during your surgery or during your CPAP treatment, post-treatment. So the future is going to be a combination of these physiological biomarkers, circulating chemical biomarkers, and the genomic study. So I already summarized why a composite biomarker is required and not just a sleep study. So one more thing, all these biomarkers are in investigational right now. None of them are being recommended by American Academy or any other guidelines. But as we have been seeing many a times, today's research are tomorrow's guidelines or could be our tomorrow's standard of care. Thanks for the opportunity. Any queries?
So thank you, sir, for your futuristic presentations. And the point about hypoxic burden is very well taken, sir. But the other biomarkers, I feel it is not specific to OSA alone.
Yes,
It may
yes.
vary
They
from
are overall for systemic inflammation.
Inflammation.
But what they have found is once the treatment for OSA has been started, those specific biomarkers are reducing. Quite a few, especially the oxidative stress, the inflammatory biomarkers.
Maybe used as a prognostic.
Yes, and especially the fibrotic biomarkers, now they're trying to see whether those patients are going to end up with a lot of fibrosis post-surgery and trying to, so it might play a role in your, strategizing which patient to operate, which not to operate.
Thank you, sir.
Thank you.
Thank you, doctor.